Okay. It's a great privilege for me to introduce Professor Boulton. He is a professor of medicine of the University of Manchester, and also he is a visiting professor of the University of Miami, Florida, consultant physician, Manchester Royal Infirmary, and he is past president of many, many things. He is the past president of the European Association for the Study of Diabetes, and currently he is the president of the International Diabetic Federation and EURADIA, which is the Alliance for European Diabetes Research. And on behalf of Diabetic Association, we are very grateful to you, Andrew, that you agreed to deliver this lecture. This is a very, from our point of view, this is the most prestigious oration organized by the Diabetic Association and has been delivered by distinguished in the past. And distinguished person like you has honored us to give the deliveration. Over to you, Andrew.
Professor Khan, ladies and gentlemen, many thanks for the kind words, and it's a pleasure to be joining you today, and I'm honored to receive this prestigious award of your association. I'm calling from a rather cool Manchester, and I see my friend Akhtar Hussain just finished his lecture, and I'm sure it's probably even cooler in Oslo, but I suspect it's not so cool in Dhaka and Bangladesh. So, as the introduction just said, Professor Mohammed Ibrahim was the founder of the Bangladesh Diabetes Association back in 1956, I think, and of course it was 31 years ago from tomorrow since his death, hence your meeting crosses these dates. So it is an honor, thank you very much. Now, our previous Chief Medical Officer, Salim Donaldson, said these words: "If you always do what you always did, you will always get what you always got." Now, clearly at this time, these words are even more important. We're going through a huge challenge in diabetes and its management, and a huge challenge for all non-communicable diseases because of this pandemic. And we do have a global epidemic of diabetes that many forget. There are approximately 500 million cases across the world now. In our country, the UK, 6%, but in many countries much higher. And I know that my friend Abdul Basit was speaking earlier, and he published a paper just recently showing that 26.4% of patients in Pakistan, adults, have diabetes. And as you know, in the neighboring countries such as the Middle East, there's a very high prevalence. Now, I'll say a few words about diabetes and COVID, but I will focus mainly on my main area of research, neuropathy and diabetic foot problems. And of course, this paper, and speaking as the senior associate editor of Diabetes Care, we have had a number of issues focusing on COVID-19, and this was one of the first papers to be published earlier this year in one of those issues. And the good news from Wuhan and Italy in the early days was there were few reported cases of hospitalized patients with diabetes under 35. But of course, if you look at Wuhan, 10% of COVID-19 hospital admissions had diabetes. The median age was higher, mortality was higher, and adverse outcomes, as you've heard from Akhtar, were associated to a number of measures such as age, complications, and so on. Here is a paper more recently from NHS England, currently not yet published but under consideration. And this is the impact of diabetes on COVID-related in-hospital mortality in England, a large cohort study. And this showed that 1 in 3 deaths occurred in people with diabetes, both type 1 and type 2. And we know the effect of this pandemic on non-communicable diseases in the UK and in other countries. Unfortunately, the pandemic has led to the neglect of many conditions. In a recent paper in the British Medical Journal, cancer care and heart disease was emphasized by the National Health Service, but no mention of diabetes, which is probably one of the most important non-communicable diseases. Positive improvements must be maintained. We have got reduced bureaucracy because of the need for speed in this recent pandemic. Video consultations, as you heard from Akhtar. So I think lessons from COVID-19 pandemic in the UK for diabetes. The deaths frequently occur in people with diabetes, and impact of age, overall poorer glycemic control, and other predictors of comorbidities are predictors of poor outcome. We need parity of focus on all types of diabetes, and Douglas, who just asked a question, who we were on a conference call or a video webinar last Saturday, and when we talked about intersectoral collaboration. But we need, the attention needs to be given to diabetes that it deserves at this time. So there are threats, as you've heard, and opportunities. The threats, patients with diabetes are often having to self-isolate, to shield. This leads to poor diet, lack of exercise, may impact on worsening glycemic control, and of course the psychological impact cannot be overemphasized. Fear of hospitals. I've moved my clinic to see diabetic foot patients, and I see many, away from the hospital into the community to a clinic there, because people with diabetes were too frightened to come to the hospital, often with good reason, because we had many COVID cases during the height of the pandemic. The worry is that we might be facing a tsunami of complications following this pandemic. But as you've heard, there are opportunities which we need to take up and enhance. Expansion of telemedicine, digital education, improvement of inpatient services has been forced upon us, and we should keep these. And there have been enforced service redesigns. The threats again, during the pandemic and still today, cancellation of almost all routine outpatient clinics, access to medical supplies and chains in some developing countries has been a problem. In the UK, we've had the suspension until last month of all routine investigation, including x-rays, suspension of non-emergency surgery and all transplant surgery. We do many renal and pancreas renal transplants. They've all been suspended and only just restarting. So turning now to the diabetic foot and COVID. As I've said earlier, the mortality in those with COVID-19 with diabetes occurs in the older patients, more common in males with poorer glycemic control and other complications. This is just the population that's at risk of diabetic foot problems. If you look at patients who develop diabetic foot problems, they tend to be older, male with poorer glycemic control, hypertension, and other diabetes complications. So the threats, particularly to neuropathy, peripheral arterial disease, and foot problems, has been suspension of all routine lab tests, including CRP, full blood count, electrolytes, suspension of MRIs, X-rays, non-invasive vascular tests, and non-emergency surgery, including bypass surgery. So we have reported, published in Diabetes Care in print just last month, from a tale of two cities, I call this, two diabetic foot services, and those of you who like Charles Dickens, sadly it's not London and Paris, the tale of two cities, but it's London, Manchester rather, and Los Angeles. And there, my former PhD student, David Armstrong, is professor of surgery. So we combined to look at how we've coped with diabetic foot disease during this pandemic. And we compared the caseload in the 6 weeks before lockdown, that's until the end of March, and the 6 weeks post-lockdown, April and May. And we've looked at changes in care and outcomes have been assessed. This is the most complicated slide I will make you suffer this afternoon for you. This column is clinic visits, how many telecare, home domiciliary visits, and how many patients have been hospitalized. And the 6 weeks pre-lockdown and post-lockdown for Manchester and Los Angeles. So in Manchester with diabetic foot disease, we saw 373 patients in the clinic in the 6 weeks prior to lockdown, but we continue to see many in the 6 weeks post-lockdown. We haven't got telecare, but now we do have telephone consultations. But as Akhtar said, it's very difficult to do diabetic foot care by even video consultation, but I'll give you some examples. In domiciliary visits, we've increased, and our podiatrists are visiting patients at home, and we've significantly reduced hospitalization in these patients and using good clinical medicine without the need to do CRPs, blood tests, x-rays, clinical observation and clinical care. In Los Angeles, you can see there the cases reduced remarkably post-lockdown, but they've had many more telecare with video conferencing, etc. In the United States, they don't do home visits for foot care, but their hospitalization rates also reduced by 2/3. I'll give you a few case vignettes from this series. Here's one of my patients in Manchester, a 73-year-old male, actually originally from Pakistan, type 2 diabetes with no neuropathy and ischemic heart disease. And he had just presented 3 weeks prior to lockdown with an extensive ulcer on the medial interphalangeal joint of the right hallux. No vascular disease, normal Dopplers, which we could do, and probe to bone test was positive. And this is the presenting lesion here, and you can see the ulcer here, and this was probing through to bone. This is highly suggestive of osteomyelitis. We were able to do an X-ray in the week just before lockdown, and this confirmed our clinical suspicion. You see distal phalanx and the proximal phalanx are involved here, especially the proximal end, the distal end of the proximal phalanx, with an inter-articular involvement of septic arthritis. So this is osteomyelitis in the proximal and the distal digit with inter-articular septic arthritis. Now, we decided when we saw this X-ray, we couldn't admit him. Many of these patients would have previously undergone the amputation of the hallux, but he had a good circulation. So we elected to treat him with oral antibiotics, no intravenous, clindamycin and ciprofloxacin for 8 weeks. And there is some evidence to support our action. The Aviva study I'll tell you about was published last year, but that shows that oral are just as good as intravenous in osteomyelitis. And after 6 weeks, this is what we saw. We were unable to repeat the X-ray at that time. So we saw complete healing of the ulcer, but 2 months ago, we were able to repeat the X-ray for the first time, and this showed radiological healing. So this was successful management without the need for any tests. The second case here in Manchester, again, 59-year-old man, known neuropathy, previous third ray amputation. He presented in the first week of lockdown with a grossly swollen, sausage distended, looking like a sausage second toe, with cellulitis and a plantar ulcer. He had absent pulses, monophasic Dopplers in the one of the arteries of the foot, posterior tibial was normal, the dorsalis pedis monophasic. The probe to bone test was positive, and you see this is a good clinical sign of osteomyelitis reported from friends of mine from Sheffield in the late 1990s. Sausage distension of the toe is highly suggestive of underlying osteomyelitis. No X-ray possible. We gave them the same antibiotics, and you can see the ulcer at presentation here, this probe through, and sausage-shaped distension. But after 6 weeks, we saw this, and we were able to do an X-ray again that showed radiological healing. So Professor Lindsay of Belfast taught his medical students 100 years ago many aphorisms. This is an important one for the diabetic foot. For one mistake made for not knowing, 10 mistakes are made for not looking. And the good clinical practice has been emphasized during the pandemic. Here's one of the cases from David Armstrong in California, a 68-year-old male, type 2 diabetes, no neuropathy, known arterial disease, heart disease, again, a previous ray amputation. He previously had bilateral popliteal perineal distal bypass surgery, and 2 weeks prior to lockdown presented with an open left, he underwent a left transmetatarsal amputation. Treated with vacuum-assisted closure, negative pressure wound therapy, but he had extensive slough and he was reluctant to attend the hospital clinic. So this patient was put on larval therapy by direction using a teleconference to the home visiting nurse who had never done this before. And here you see the larvae after 3 or 4 days, again being removed by instructions of the home nurse at home. And you can see a good result here. These are the metatarsals, but you see a nice clean wound. Larval therapy we use widely and used also widely in, of course, United States. Here's a fourth case, high-risk patient. It couldn't be more high risk than this, 68-year-old type 2, neuropathy, previous chronic renal failure, and a renal transplant and with arterial disease. He had an outpatient foot ulcer after his distal angioplasty with dry gangrene of the first 3 toes. Later, this progressed to wet gangrene, but he was too frightened to come to hospital for many reasons. Obviously, he was immunosuppressed, very high risk were he to catch COVID-19. He, like our cases, was treated with oral antibiotics, and he was unable to go a left open partial amputation of toes 1 to 3 under local anesthetic in a site away from the hospital. Here is the case. You can see definitely gangrenous toes here. And this was operated on away from the hospital in a community clinic with a good end result, foot saved. So, as I said, there are many threats, but there are also many opportunities. And telecare, even in advanced foot care, has been possible. Now let's turn to the diabetic foot in general, and it was Voltaire who wrote these words, that the art of medicine consists of amusing the patient while nature cures the disease. Now this may be true for many conditions, but certainly not for diabetes. And this was a case who I met when I first came as a consultant to the Manchester Royal Infirmary in 1987. And as you can see, clinical observation here tells you that this patient's got major problems. She just started peritoneal dialysis for chronic renal failure. She couldn't focus because she was blind from diabetic retinopathy. She had ischemic heart disease in her 40s. You can see the patch here and the scar from a previous CABG, and she had no legs. This is what I call malignant diabetes. The outlook for people like this is worse for almost every form of cancer. So we have to take diabetes seriously. And she wanted me to take a photograph to say, please, can we do something to stop this happening to other people? And we can. So let me talk about some of the successes and failures in prevention and treatment of diabetic foot ulcers. If you ask who is at risk of foot problems in diabetes, people under all these categories are at increased risk. And perhaps the most at risk of all are patients who've got a past history of foot ulcers. Even in the best clinics, the recurrence rates are 30 to 50% per year. And also those who, of course, have already lost part of a foot or leg. But we've shown in prospective study that neuropathy is a huge risk factor, especially in countries like yours in the Indian subcontinent. Very huge risk factor for foot problems. And it was Dr. Paul Brand, who worked for many years in CMC, Christian Medical Center in Vellore, in Tamil Nadu. He worked in leprosy, later in diabetes, and we learned how to look after the insensitive foot in diabetes from countries such as yours, such as India, Ceylon, now Sri Lanka. And he said, talking about leprosy, that pain is God's greatest gift to mankind, a gift that you only realize when you've lost that gift of pain. And he made some profound but very true clinical observations. First of all, any patient with a plantar ulcer who walks into your clinic without limping must have neuropathy. Corrigan, he was an Irish physician, and you can see his bust in the Royal College of Surgeons in Dublin. He wrote these words, and it's true. The trouble with most doctors and medical students is not that they don't know enough, but they do not see enough. They look, but they don't see. And that's why clinical assessment and clinical examination of the diabetic foot is so important. And to date, we can't do that virtually. And he also said this: you do not need expensive equipment to diagnose the at-risk foot in diabetes. You do not need. And I've visited Indian subcontinent numerous times. First of all, I met Paul Brand in Madras, now Chennai, in 1985, and visited Vellore and Karigiri, his leprosy diabetic foot center there. And he said, the most important thing to examine the diabetic foot is not to ask the patient how are your feet, but to remove shoes, socks, and sandals, whatever, and look at the feet. Clinical observation. This is a sign we described when I was working with John Ward in Sheffield in the 1980s. This distended dorsal foot veins you see here that remain distended when you elevate the foot. These are a sign of autonomic neuropathy in the absence of vascular disease due to release of vascular tone, increased arterial inflow, arteriovenous shunting. And we showed in a paper in 1982 that if you take blood from these distended veins, the oxygen levels are almost arterial because of arteriovenous shunting. This is a good clinical sign of risk. So the warm but insensate foot is the at-risk foot. Now, I know in the Indian subcontinent that the barefoot gait and using of chappal like sandals is very common. But patients, they come to the clinic, they like to look smart. This patient unfortunately bought these shoes, which I've yet to find a human foot in these shapes. But the result of wearing those for 3 hours was this, entirely preventable. We've done a number of studies supported by American Diabetes and British Diabetic Association and about 10 years ago, looking at the relationship between renal disease and foot problems. You saw from that slide of that unfortunate lady. Dialysis and foot ulceration. We've shown that dialysis is an independent risk factor for foot ulceration. If you compare patients on dialysis with those with end-stage renal disease not yet on dialysis, those on dialysis have a 4-fold increased risk of foot problems. Mortality is horrendous. And we believe there's a need for foot care on dialysis units. You've got patients sitting there for 4 or 5 hours. First of all, they may get heel ulcers because they don't move around on dialysis. And this is an ideal opportunity for education, perhaps from a diabetes nurse. We know from this study between ourselves and Larry Lavery's group in Dallas, cumulative survival after amputation is horrendous, and especially if you're on hemodialysis, look at that. In this study we presented the American Diabetes meeting in 2012. We followed up in my unit 192 diabetic patients on dialysis for 2 years. The mortality was frightening. As I said, extremely high. If you'd lost a toe or part of a foot or a leg, 3 out of 4 patients are dead within 2 years. And as I said, this is horrendous. This is worse than almost every form of cancer. And yet, I bet if we were collecting outside a store in Dakar for charity, there was 1 bucket for cancer, 1 for heart disease, 1 for diabetes. I bet you 90% would go to cancer. Look at these statistics and remember. Now some of our more recent research looking at falls in people with diabetes. We know that diabetic patients with neuropathy are 15 times more likely to fall than age-matched controls. We've shown that unsteadiness is a huge symptom, but patients don't put this down to diabetes, they put it down to aging or something like that. So our patients are at risk. Unsteadiness is a major symptom, neuropathy is an independent risk factor for falls, and unsteadiness, trips and falls might predict the Charcot foot, as we've shown in a few case series. Unsteadiness. Here's the link. We've shown that unsteadiness is a very common symptom of neuropathy. It's predictive of depressive symptoms. Patients are depressed. They're falling and tripping, but people think they're drunk or there's something wrong with them, but there's nothing to see. We know that unsteadiness is the strongest determinant of not following advice to offload using a boot, for example. And patient perception of unsteadiness, we've shown, correlates strongly with lab tests. We've been able to do studies of patients not only walking on the floor, and here's some forced plates, but also we can assess patient steadiness or unsteadiness when climbing up or down stairs. So working with Professor Neil Reeves in his gait laboratory, we've looked at how patients can cope. We have a camera system, and here's Professor Reeves tagged with reflective markers, and the camera system's all round, so we can assess gait. Now, I'll see if this will work. I hope it's moving for you. This is a normal individual coming down the stairs quite well. But look at this patient with neuropathy. A slower speed, spreading out the arms, unsteady, and this is what we see. So there's normal, faster, unsteadiness on stairs. Common accidents of falls occur on stairs, most commonly when descending, but also occasionally when ascending stairs. So what we've shown in our recent studies and a series of publications in the last 5 years is that diabetic neuropathy and the mechanisms underpinning falls, we've shown the rate of joint muscle contraction, visual gaze is disturbed, and balance is disturbed. We've shown that there's a higher metabolic cost of walking. We're looking at the role of the Achilles tendon, non-enzymatic glycation, and we're looking at muscular impairments. Now, this, I apologize, I said that the previous slide was the most complex. This has to win the prize for the most complex slide I will show you. But it just looks at pathways to ulceration. And somatic sensory neuropathy here, or motor neuropathy and autonomic neuropathy. Somatic neuropathy leads to decreased pain and proprioception. Somatic neuropathy, motor neuropathy, small muscle wasting, altered stress through the muscles, altered pull of the muscles, and this leads to foot deformities, clawing of the toes, prominence of the metatarsal heads. Autonomic neuropathy leads to altered blood flow, as I've shown you, increased blood flow, distended foot veins, the warm foot, and decreased sweating. Sweating is, of course, controlled by the sympathetic autonomic nervous system, a cholinergic pathway, and usually for the sympathetic nervous system, leads to dry skin. Dry skin, high foot pressures, leads to increase of dry skin, callus. Callus causes, acts as a foreign body and can cause ulcers. And this diagram was designed by my wife and colleague, Dr. Loretta Villikite. And what patients can do are in the green circles by examining their feet daily, checking inside their shoes, not walking barefoot, by moisturizing the feet to replace the lack of sweat, regular podiatry, good shoes. And if you get an ulcer, it helps to wear the offloading device. Now, H.G. Wells said these words, that human history becomes more and more a race between education and catastrophe. Let's hope that education prevails, and I know there's a session later on, a panel discussion on this very topic. So in patient education, the key question in the diabetic foot is that, can education alone reduce the incidence of ulcers? Well, for primary prevention, the patient who's at risk but hasn't had an ulcer, sadly, this meta-analysis from Utrecht in the Netherlands shows that insufficient robust evidence to support education alone in the reduction of the incidence of foot ulcers. You might be surprised to hear this, but that's the case. Too many trials, but too few trials are well designed. Insufficient numbers, insufficient power, insufficient duration. But we mustn't interpret this that education doesn't work. This is lack of evidence, not evidence of no effect. Can the team approach help? Well, the answer is yes. This is from my good friend Jerry Raymond's group in Ipswich. And he showed in Ipswich, which is in eastern England, with a resident population that isn't very mobile, in an 11-year prospective study of hospital admissions for diabetic foot problems, at the beginning of this, they established a multidisciplinary diabetic foot service, regular foot care, diabetes education through a nurse, good shoes provided, and so on, regular checkups. This led to a 62% fall in major amputations, all amputations down 70%. This, I can't say that's education, but education as part of a package has been shown to help. So perhaps a patient with a secondary risk of ulcers, they've had one, can we stop them getting another one? The patient needs to do something themselves in addition to not walking barefoot, etc. And this is a study again from Paul Brand. This was published in 1975 in the Rehabilitation Medicine Journal. And he said he thought that the foot warmed up before it broke down. And this foot is clearly going to break down. And this patient's probably been lying with neuropathy in a bed, and perhaps in a surgical ward in the hospital, and nobody's bothered to turn the patient. And he showed if you do thermography here, these areas, as you can see here, actually have increased temperature. So the question now is, can we stop nerve damage plus mechanical stress leads to inflammation? Can we stop the next step to ulceration? Perhaps measuring, having the patients with a foot self-temperature monitor can help. I haven't got time to go through the details, but this is a study from Larry Lavery and David Armstrong, published in Diabetes Care. And this is the group that was self-temperature monitoring. These patients all had a history of neuropathic foot ulcers, were followed for 15 months, if I remember, and the cumulative survival without an ulcer. Only 8% recurrent ulcers in those patients who were self-temperature monitoring, but the other groups that had good education, good care, and were asked to make a record of what they found, had a 33%. So education plus an intervention the patient can do, such as self-foot temperature monitoring. The foot warms up before it breaks down. So this is a quote from the Scottish poet Thomas Campbell. He wrote these words: "Coming events cast their shadows before." So the shadow of risk in the diabetic foot is neuropathy, high foot pressures, clawing of the toes, prominent metatarsal heads. But this is surely casting a big shadow way before the ulceration. So can we use modern technology in this area? And the answer is yes. This is Dr. Ran Ma, who set up a company to design smart socks that can measure pressure and temperature in the patient whilst they're walking. And they won the Consumer Electronics Show prize for the best development that year. And what they showed is obviously a very high risk foot here on clinical observation. If you look at this foot, it has a higher temperature here, higher temperature, and this is signs of actual inflammation. So you can use smart socks. Here's smart mat technology. This is like a bath mat, but it's a smart bath mat. It's a thermometric foot mat that measures temperatures and feeds back using Bluetooth technology or whatever. I'm no expert, but it feeds back and reports on the skin temperature. And what this study was the first one to follow patients with high risk. That all they did was stand on the bath mat twice a day, and what they found was that the plantar temperature asymmetry predicted foot ulcers. This was no intervention, just observational. 28% of these high-risk patients had foot ulcer episodes, and they could predict who was going to get an ulcer by a consistent, over 2 days, if I remember, 2-degree asymmetry, 2 degrees centigrade prediction. Therefore, if you've got the patient with education, they stand on the mat, and they get a phone call from perhaps their home visiting nurse and said, look, your right foot's actually warm, I think it's at risk, you need to rest for 2 days, this can be impacting and reducing ulceration, and such trials are now ongoing. We've developed at the Manchester Metropolitan University of Manchester, this is my colleague Professor Neil Reeves, a pressure sensing smart insole that might reduce foot ulcer incidence in the high-risk patient. And we know from our studies back in the early 1990s, this study we started in 1988, if I remember, that diabetic foot ulcer risk is predicted by high foot pressures in the insensitive foot. And here's showing very high foot pressures in this area here in this one patient. We've shown, therefore, that laboratory measures can predict ulcers. But can we use a smart insole and use that for pressure feedback? Therefore, we investigated the efficacy of a pressure-sensing smart insole for reducing foot ulcer incidence. And here is the insole. It fits into this shoe here by this company in Canada. And this was supported by Diabetes UK, the study, and the company. And we had this fit in the shoe, a randomized single-blinded controlled trial with 18 months follow-up. And these pressure sensors fed back to a wristwatch that the patient wore, you can see here, and they could see a picture of their own feet whilst they were walking, and it would alarm if there was a high-pressure area, and the patient could learn to change their gait to reduce this pressure. And what we showed was that the feedback led to a reduced ulcer incidence by 71%. In those who were very highly compliant, it was 86% reduction. The study ulcer rate was low, but the mechanism of pressure offloading, feedback, and patient empowerment here. So lastly, what about new developments in treatment? A foot ulcer should heal if there is an adequate arterial inflow, if infection is appropriately managed, and pressure is removed from the wound and its margins. And factors that enhance wound healing here are controlling infection, good vascular reconstruction, we're getting good at peripheral arterial bypassing, adequate glycemic control, but most important to offload the pressure. So it's what you take off the wound that matters most. Take pressure off and take dead skin, non-viable tissue through surgical debridement. The best way to offload is still what we learnt from leprosy in the Indian subcontinent, and that is a total contact cast or a below-knee cast, but we do have removable casts as well. These work just as well as the below-knee cast as long as the patient wears it. But there has been a renaissance in diabetic foot care in new trials coming out over the last few years. The recent guidelines on the design of trials that Jeff Gert and myself and others have put together are now being observed, and there have been a number of well-designed randomized controlled trials published in the last few years. And I'll show you one or two examples, and other studies are ongoing. This was the leuko patch system published in Lancet Diabetes Endocrinology by Fran Game and colleagues. And this was bedside centrifugation without any additional reagents to develop a disc, to generate a disc of autologous leukocytes, platelets, and fibrin that then you apply to the ulcer. And this showed significantly faster healing and reduction in ulcer area in those treated with the leuko patch system. And then there was this one by Mike Edmonds and colleagues, my good friend Mike Edmonds at King's College in London, sucrose octasulfate dressing in neuroischemic ulcers, a randomized controlled trial, again in that same issue. This was a large multinational randomized controlled trial of this dressing in neuroischemic ulcers, a large number of patients showing significantly faster healing in the sucrose octasulfate group. This is the first dressing that has been proven to be a good medical therapy for neuroischemic ulcers. There have been a host of topical oxygen devices, and a study just published by Bob Freiberg this year in Diabetes Care suggests that topical oxygen, not hyperbaric oxygen, topical oxygen may be useful in speeding up wound healing. What about infection? Well, despite all the progress, we still use clinical criteria to define infection. No doubt in this foot, and those of you who are still awake will see that there is here a Charcot deformity at the cuneiform metatarsal joint in this patient's foot. He's probably got a dropped cuboid bone, and he's got an abscess here, erythema, purulent discharge, signs of infection. Pain is unusual in the insensitive foot, so if you've got a patient with an ulcer and pain, take that seriously as likely infection. And remember that antibiotics are not growth promoters, they're not wound healing agents, they're not household cleansers. Antibiotics don't heal the foot ulcer, they treat the infection. And the Infectious Diseases Society of American guidelines are about to be republished, are more up to date, but their simple classification of foot infections into mild, moderate, or severe. The staphylococci remain the commonest infecting organism. Broad spectrum antibiotics first, then home in on your cultures, and cultures should be deep ones. Wound swabs are not very good. And foot care teams can improve outcomes. Here's a study from friends in Derby and ourselves. These are retrospective studies, not as good as prospective studies, but this suggested that antibiotics can be used in osteomyelitis, localized, without the need for surgery. But this has been confirmed in this study, which was published a few years ago from colleagues in Spain, a proper randomized controlled trial where they randomized patients with localized osteomyelitis to either local surgery or antibiotics alone. There was no difference in outcome. So antibiotics alone can be used in osteomyelitis in neuropathic feet. But this was the study I referred to earlier, the AVIVA study, which is easy oral versus intravenous antibiotics in osteomyelitis. And this showed non-inferiority of oral, non-inferiority versus IV. So there's no evidence to say you have to have IV antibiotics for osteomyelitis. So let me draw to some conclusions here. That although the incidence of diabetic foot ulcers continues to increase, there have been major advances in recent years. Infections, randomized controlled trials are at last guiding us on management. Therapies, well-designed trials, providing evidence of efficacious medical therapies, as I've shown you, and smart technology is really revolutionizing our approach to prevention of foot ulcers. And perhaps the Internet of Medical Things will provide us with huge opportunities for the future of diabetic foot care. But still, that working together as a team matters. I was in my big multidisciplinary face-to-face diabetic foot clinic yesterday with a microbiologist, a vascular surgeon, a podiatric surgeon, 8 podiatrists, a diabetes specialist nurse and educator, a shoe fitter, an orthopedorthist. These are all important. For the patient is the most important. So get the patient involved, as this quote from Wilson, you teach me and I forget. You show me and I remember, so perhaps showing slides is slightly more helpful. You involve me and I understand. So involve your patients, especially those with a history of foot ulcers, in self-care and perhaps using new technologies as they become available. So I'll leave you, sadly, for the first time, and I started this with my colleague Henry Connor in 1986, the first International Diabetic Foot meeting. These occur every 2 years, and Abdul Basit, and many people watching may have been to these, and Abdul Basit spoke at one of our meetings. And this will now be rerun next year. For the first time, we're going to an odd year, but I'm sure it won't be an odd meeting. So I thank you very much for your attention, and thank you for the honour of the lecture.